Did you know that an MRI machine can cost roughly $3 million? It can see inside your body without cutting you open. It shows the bones, the muscles, the tendons, the cartilage, blood vessels in incredible detail. A specialized doctor spends years learning to read these images. They write detailed reports describing everything they see. The conclusion says no significant findings, normal study. But you're still in pain. Pain that's real. Pain that has been there for months or years. How can $3 million machine that sees everything see nothing at all? The doctors show you the images. They point out your hip joint, your cartilage, your labrum. Everything looks healthy. No tears, no arthritis, no structural damage. The implication, if the MRI is normal, you should be fine. But you're not fine at all. So what's the problem? Is the MRI wrong? Is the doctor missing something? Or is there something else going on? The MRI isn't wrong. The doctor isn't missing anything. The MRI is showing exactly what is designed to show. The problem is what is designed to show and what it can't show. And that's the gap. And that gap, that's where women's hip pain lives. Let's start with the MRI actually does. MRI stands for magnetic resonance imaging. It uses powerful magnets and radio waves. Without getting too technical, it makes the hydrogen atoms in your body line up, then measures how they respond when the magnetic field changes. Different tissues respond differently, and that's how it creates the image. And then the results, incredible detail images of anatomical structures. MRI is excellent at showing bones and bone's marrow, cartilage, tendons and ligaments, muscle, the tissue itself, fluid collections, inflammation in tissues, tumor or massive, and blood vessels. It's structural imaging. It shows you the anatomy, what's there, and what it looks like, whether it's damaged. For the hip MRI, the radiologist looks at the bone, so your femur, pelvic, looking for fracture, bone marrow changes, arthritis. Then the cartilage, so covering the bone, looking for thinning or damaging. Then the labrum, the cartilage rim around the socket, so looking to see if it has a tear. The tendons, they're looking for tears. The muscles, they're looking for tears again. The bursa, they're looking for fluid indicating inflammation. The joint space, they're looking for fluids indicating inflammation. The radiologist goes through a checklist. Each structure, is it normal or abnormal? Is everything on the checklist checks out as structural normal? The report says normal or no significant findings. This is accurate. Structures are normal. But here's what the MRI fundamentally cannot show: how muscles are functioning, which muscles are activating during movement, the sequence of muscle activation, muscle coordination patterns, motor control, joint stability during movement. MRI can't detect pain signals. That would be pretty awesome. Compensating patterns, how the body distributes load, pelvic floor coordination, and core stability during functional tasks. Why can't it show these things? Because the MRI requires you to lie completely still. And movement creates motion artifacts. It blurs the image, making it unreadable. So if you lie still, flat on your back for, say, 30 to 45 minutes, not moving, not bearing weight, not loading the joint, it's a static snapshot of structures at rest. But your pain happens with movement, with weight bearing, with functional activities. The MRI never captures that. So here's the analogy. Imagine your car is making a strange noise when you drive it. The mechanic examines your car while it's parked, engine off. They look at all the parts. Everything looks fine. No cracks, no damages, no wear. They say everything looks normal, your car is fine. But the noise only happens when the car is running, when the parts are moving and interacting under load. The static inspection missed the dynamic problem. That's what happens with the MRI and functional hip pain. The static structure looks fine. The dynamic function is the problem. Now, I want to talk about how MRI technology was developed and what was optimized to detect. MRI was developed in the 1970s, became clinically available in the 1980s. Early orthopedic MRI was revolutionary for diagnosis. ACL tears in athletes, meniscus tears in athletes, rotator cuff tears, fractures, and bone tumors. The patient gets orthopedic MRI in the 90s were predominantly male athletes with acute injuries, older patients, both genders, with severe arthritis, trauma patients with fractures. What these conditions have in common is clear, visible structural damage. Torn ACL. The ligament is visibly disrupted on imaging. The cartilage shows a tear clearly. Rotator cuff tear, the tendon is visibly separated from the bone. So MRI protocol were optimized for detecting these acute structural injuries. Specific imaging sequences were developed to show these structures in the clearest detail. Radiologists were trained to identify these specific pathologies. Now, we're going to fast forward to today and consider the typical women with postpartum hip pain. No acute injury or trauma. Pain developed gradually over months, gets worse with certain movement, may have started during or after pregnancy, multiple pain locations, pain patterns that moves or changes. This is nothing like an ACL tear or meniscus injury. There's no sudden structural damage to see. So what is actually happening is that muscle coordination breakdown, altered movement patterns, compensating strategies, chronic overload of certain structures, functional instability. None of this shows up on standard MRI protocol. Why? Because MRI was never designed to detect functional problems. It was designed to detect structural injuries in male athletes. The specific biomechanical changes that happen during and after pregnancy is ligament laxity that persists, altered pelvic alignment, changed muscle recruitment patterns, pelvic floor dysfunction, and core coordination disruption. These don't create the kind of tissue damage that's visible on an MRI, at least not the early stages, not for years. Eventually, after years of compensating, you might develop mild labral phase from abnormal joint loading, early cartilage damage from altered weight distribution, and chronic overload. But by then, you've been in pain for years. And even then, the MRI findings are often described as mild or age-appropriate changes, which doesn't explain the level of pain or dysfunction you're experiencing because the MRI is still showing structure, not the functional pattern that caused structural changes. Radiologists go through about 4 years of medical school, 5 years of radiology residency, and often 1 to 2 years of fellowship. They look at thousands of images. They learn to identify pathologies. They develop pattern recognition for structure abnormalities. For hip MRI, they're trained to systematically evaluate fractures, acute or stressed, bone marrow edemas, vascular necrosis, arthritis, bone tumor lesions. See if your cartilage has thickened, signal changes indicating damages, or arthritis. Your labrum is see if it's got tear, the location, the size type, degenerative changes. Your tendons, gluteus medius and minimus tears, hamstring tears, an attachment, muscles for tears or strains, strophy, like the muscle wasting, masses, bursitis, see if it's greater versus, so it's like the fluid in bursitis, joint. Then other things that they find is like joint infusion, so the fluid in your joint, inflammation of the joint lining, nerve impingement. The radiologist goes through each structure systematically. They compare what they see to what's normal. If everything looks structural normal according to their training, they report negative study or no significant findings. But here's what they're not looking for because they weren't trained. Muscle size asymmetry between sides might indicate one side overworking. Muscle signals change without obvious tears might indicate chronic overload. Minor alignment variations might indicate altered load patterns. Ligament laxity without tear. So that's a pregnancy related. Pelvic floor, why aren't they looking for these? Because they aren't part of the standard reporting protocol. They're not considered significant findings by standard radiology standards. Let's say left glute medius measures 2.8 centimeters thick. Right glute medius measures 2.1 centimeters thick. That's a 25% size difference. That might indicate that the right side isn't activating properly, leading to atrophy, or the left side is overworking to compensate, leading to hypertrophy. This could be clinically important information for understanding the patient pain pattern, but it typically doesn't get mentioned in the report because there's no tear, no obvious pathology. Both muscles are within normal limit. Normal is defined structurally, not functionally. Another example would be the MRI might show subtopelvic rotation. This affects hip mechanics significantly, but it's not pathology. It's alignment variation. So it doesn't get reported as significant findings, even though it might explain the patient's pain pattern. The radiologist is not being neglected or missing something. They're reporting exactly what they're trained to report: structural pathology that meets diagnosis criteria. Functional markers of movement dysfunction aren't in their diagnostic framework, not because those markers don't exist on the images, but because radiology training doesn't include functional analysis. So let's look at a typical normal hip MRI and what it actually says. Here's a report from a woman with chronic pain. Clinic indication: right hip pain. Technique: MRI of the right hip was performed without intravenous contrast. I would definitely recommend getting contrast. So there's no fractures, bone marrow edema, or focal lesions. No significant arthritis. The labrum demonstrates normal morphology and signals no tear identified. The cartilage, articular cartilage, is preserved too. No chondral defect. Muscles and tendons: the muscle medius and minimus. The glutes medius and minimus tendons are intact. The tendon is normal. The muscle tear, or there's no muscle tear or significant atrophy. No bursitis. No joint fusion. No significant abnormality identified. This is considered a completed normal study. Patient's reality: can't walk more than 20 minutes without severe pain. Can't pick up a child without sharp groin pain. Can't sleep on that side. Has been in pain for 14 months. Pain starts 6 months after having a baby. How can an MRI be normal and the patient be in severe limiting pain? Here's what the report is actually saying. We looked at the structures we're trained to look at. We used the criteria we're trained to use. We found no pathology that meets our diagnosis threshold. Therefore, by our standards, this is normal. It's not saying nothing is wrong with your hip pain, but you shouldn't have pain. The pain is in your head and you're fine. That's not what it's saying. It's actually saying the structure we can see with the MRI appears intact. We found no tears, fractures, or significant structural damage according to standard diagnosis criteria. What it doesn't address is how are those structures are functioning, whether muscles are activating properly, whether joint stability is maintained during movement, whether load distribution is normal, whether compensating patterns exist, whether floor is functioning, whether core is stabilizing effectively. These questions are required different forms of assessment: dynamic assessment, movement analysis, functional testing. Let me give you a specific example. 2 women, both right hip pain after pregnancy. Women A, MRI is moderate labrum tear posteriorly, mild arthritis, and mild bursitis. Women B's MRI is no significant abnormality. Based on the MRI, you'd expect women A to have the worst pain and dysfunction, right? Actually, woman B has more severe pain and greater functional limitation. Women A can walk 30 miles, climb stairs, play with her kids. Pain is 3 to 4 out of 10. It's manageable. But woman B can't walk more than 10 minutes, can't climb stairs without severe pain, and can't pick up her child. Pain is 7 to 8 out of 10, and it's debilitating. How is this possible? Woman A has structural damage visible on MRI, but relatively good functional movement patterns. her body compensates effectively for the structural issue. Woman B has no structural damage on MRI, but severe functional movement dysfunction. Her movement patterns create abnormal loading and pain, but haven't yet caused visible tissue damage. The MRI can't explain this difference because MRI doesn't show function. Research has shown that correlation between an MRI findings and pain severity is actually quite weak. Studies have found 73% of asymptomatic people, so no pain, have labrum tear on MRI. 69% of asymptomatic people have cartilage defect. 27% have bone marrow edema patterns. Many people with significant MRI findings have no pain. Many people with severe pain have normal MRIs. MRI findings don't reliably predict pain or functional limitations. Yet, treatment decisions are often based heavily on MRI findings. If MRIs show tear, surgery is recommended. If MRI is normal, there's nothing structurally wrong, so there's nothing we can do surgically. Both approaches miss the potential functional problem. Now, let's talk about specific pregnancy-related changes and why they don't show up on MRIs. During pregnancy, your body goes through massive biomechanical changes. All ligaments become elastic. Joint stability decreases. This is necessary for childbirth. There are functional changes, not structural damages. On MRI, ligaments might look slightly thicker from fluid retention. Normal signal, no tear, within normal limits. But functionally, they're providing less stability than pre-pregnancy. MRIs can't measure ligament tension or functional stability. It can only show if the ligament is torn or not. The abnormal wall stretches significantly, sometimes separated. That's the diastasis recti. The MRI can see that the recti exists and measures the gap. It can't show if the core is functioning properly. Two women with the same 3 centimeter diastasis. Woman A, core coordination well, no pain, good stability. Woman B, core doesn't coordinate, pain, poor stability. Same MRI appearance, completely different functional status. The pelvic floor undergoes massive stress during pregnancy and childbirth. Stretching, sometimes tearing, nerve damage, loss of coordination. Standard hip MRI has limited visualization of the pelvic floor. Even with specialized pelvic MRI, you can see major tears, significant atrophy, and prolapse. But you can't see whether it's coordinating with breathing, whether it's providing pelvic stability, whether it's contributing to hip control, timing of activation, strength, and endurance. These functional aspects determine whether you have hip pain, not the structural appearance. During pregnancy, the pelvic tilts anteriorly, so it tilts forward. This changes hip joint mechanics and muscle length tension relationships. After pregnancy, this should return to neutral position, but often it doesn't fully correct. MRI shows the position of the bones in that moment, but it can't show if this position is creating abnormal joint loading, if the muscles are compensating for the altered alignments, if the movement patterns have adapted the misalignment, whether this can be corrected. Your brain controls the pattern of the muscle activation. During pregnancy, these patterns change out of necessity. After pregnancy, they might not spontaneously restore. Your glutes might stop activating properly. Neural drive decreases. On MRI, the muscles might look slightly smaller after time or might look completely normal. But the MRI can't show how much the muscle is actually being used, the neural drive to the muscle, the timing of the activation, and the coordination with other muscles. This requires an EMG or movement analysis, not visible on static imaging. All these pregnancy-related changes are real. They affect function significantly. They can cause chronic pain, but they can't show up as pathology on a standard MRI because They're functional changes, not structural damage, and this is imaging gap. So if the MRI can't show functional problems, what? There are other methods that can reveal functional dysfunction. Ultrasounds can perform while the person is moving. You can watch muscles activate or not activate in real time, particularly useful for pelvic floor assessments. You can see if the muscle contracts when it should and how much in the coordination with other muscles. But this requires specialized training and equipment, not standard in orthopedic practice. Measures electrical activity in muscles can show which muscles are activating during the movement, timing, and intensity. Mostly used in research setting, not clinical practice. It's expensive and time intensive. High-tech systems that track movement in 3 dimensions can show movement pattern, joint angles, and force distribution. Very expensive. Primarily research tools. Some specialized sports medicine clinics have versions of this, not accessible for most patients though. This is the most practical and accessible option. A trained professional observed how you move, performs specific tests to assess this, could be which muscles are activating, coordination and timing, compensating patterns, stability and control, movement qualities, combined with detailed history, pregnancy and birth details, when pain started, what makes it better or worse, pattern of pain through the day, functional limitations. This comprehensive assessment can identify functional movement problems that the MRI just misses. Doesn't require expensive technology, requires time and expertise. Typically 60 to 90 minute initial evaluation. But do you remember what we talked about with insurance? Typical of comprehensive assessment, it doesn't reimburse well. It approves 30-minute PT evaluation seeing multiple patients simultaneously. Can't do comprehensive movement assessment in that time with that structure. So most patients don't get this level of assessment. They get an MRI instead, which costs more than $100 to $1,200 for MRI versus $200 to $300 for comprehensive PT evaluation. But the MRI is the standard of care, even though it often misses the actual problem in functional pain. The system is backwards. We're using expensive technology designed to show structure for problems that are functional, then say nothing's wrong when the structure looks normal, instead assessing the function in the first place, which could cost less and be more accurate, but would require changing diagnostic protocols, training providers in movement assessments, reimbursing comprehensive evaluation, recognizing functional diagnosis as valid. So women get MRI comes back normal. Women are told nothing's structurally wrong, and they're still in pain because the MRI was never designed to see their problem. The imaging gap isn't a technology problem. It's a framework problem. We're using structural imaging for functional problems and calling it normal when we don't see structure damage. But the normal structure doesn't mean normal function. And that gap between structure and functional is where millions of women hip pain lives.